Well, welcome, and for those on the web, I'm Walt Medlin. I'm one of the surgeons here at Peace Health, and the hometown bariatric surgeon. There are going to be other surgeons possibly operating at Peace Health in the bariatric program. I think we're just going to have to see where that goes, but the hospital has made a commitment to start going down the path of getting a center of excellence together, and I think as we talked about, both 2 and 3 are reasonable general surge floors, but with 3 especially getting spine and you guys sort of needing more work, I see that this is a good place to start. Smaller nursing cadre, so we can do team building, I think, easier than with a larger nurse cadre. And so thanks for coming today, and a lot of what I want to talk about is basically how we're going to build a team, how we can work together as a team, because I think that's really critical that you guys at the point of care be empowered to feel like you're going to be listened to if something just doesn't seem right, that you don't have to call with 8 data points, and say this and this and this and this, you got to come in. I prefer if you have all your data together, and you know what's going on, but early on with weight loss surgery, that first night or two, they're big operations, and they're patients who don't necessarily so like some trauma patients, they don't necessarily show you a lot of signals early, and so being sort of extra tuned into what can happen and just having gone over it, I think is really helpful, just to know what sort of my priority list is going to be when you call me on the phone. What am I going to be concerned about? And of course, all I'm concerned about is what's best for the patient, so it's just sort of working from most common to least common, or riskiest to least risky. I do think it's important working together as a team, that we have, that trust, that that you'll call if I write something that's weird, that it doesn't just wait to the next shift, or that you'll ring me up. Okay, so please, I'm inviting you to, don't call me just because you're lonely, but otherwise, if it's something that's impacting the care of the patient, sometimes we're a little testy on the phone, but it doesn't mean I'm not really appreciative when people are making sure that the caring is there. So that teamwork also comes through for the patient experience, and having a really good program means taking care of that patient in sort of the antique way of care, even sort of before nursing and before doctors, of just being there for the other human being. I think we can sometimes, with modern medicine, we can give superb, excellent technical care, but when there's, especially with something like obesity, when there's bigotry in a society, or there's bigotry in an institution, it can come through, and it's not as much a problem in 2010 as it was 15 years ago, 20 years ago in some programs. But society really is still bigoted against obesity as a disease, and people are very tuned into that. And I do want to remind you that this is a 3 minutes of sensitivity talk in a 45-minute talk, but sensitivity is not just an act, it's not just a presentation, it really does need to be real. And if it can't be real, then you should probably get somebody else to take care of that patient. If you can't really in your heart treat them like everybody else, then let somebody else do it. And I also want to just say that I know we have conflict with patients, and we can have conflict with these patients. That's allowed, okay? Sometimes they're unreasonable, sometimes we're unreasonable, especially surgeons. But conflict is not what I'm afraid of. It's more the disparaging remark in the med room, or even weirder, in the parking lot or at the mall. You never know. People recognize you guys as nurses, and a remark in the parking lot is just as damaging. You know what I mean? So just be careful. We all it's a snarky world, and we're allowed to have, certain opinions about individuals, but we have to make sure that we not generalize, okay? And that we really be careful about some of those trigger words that can be taken way out of context, because it can doesn't happen often, but I just think it bears reminding. The sensitivity part of it is not hard to do, but it just needs to be at the core of the care, and that alone will make people happy if they know that we're really providing honest care. So then on the technical side, which is what most of the rest of this is about, we'll get to that, but I also wanted to just, as the part of the sensitivity part of the talk about the disease model of obesity, that this is not just a disease of naughtiness or poor willpower, any more than wearing eyeglasses is a failure to squint enough. Okay, definitely people who are heavy tend to eat. I mean, for sure, there's physics. You know, people are heavy, and you guys know I'm a weight loss surgery patient. You eat more calories than you burn, and definitely when people are hungry all the time, they do tend to eat naughtier food more often. However, even our and naughty is a really good word because a lot of what I end up talking about with patients, and again in the text of this talk I can't really talk too much about it. There's a real problem with the boundary between responsibility and shame and blame. You know, and with most medical diseases, people say, "Oh, I've got COPD." You know, even if they're not a smoker, you know, or even if they say, I smoked, I got COPD, but they don't go around whipping themselves, beating themselves up about it 24 hours a day. They don't go into the asthma clinic and have people, you know, sternly look at them like, you know, yes, they have responsibility for showing up for care. They need to be a partner in their care, and they need to take their meds on time, but nobody blames them necessarily for the disease. And in obesity, a lot of times it crosses that line into blame and shame. And I always say that, you know, as bigoted as society is, medicine is more bigoted, and surgeons generally are the most bigoted of doctors. And it's been a real problem with weight loss surgery getting established because the surgical literature, the surgical societies were very slow to really buy into the fact that this is valid care. You know, that it's not just an easy fix. You always see People magazine, right? At least once a year they say, they did it naturally. No tricks, no gimmicks, no surgery. Well, that must mean that surgery is a trick or a gimmick, right? And it's not, any more than cancer surgery is a trick or a gimmick. You know.
I think people see it as an easy way out.
They see it as an easy way out. They think that people are not taking responsibility, whereas in fact it really is people taking responsibility. And that's where, again, the disease model for obesity includes patient behavior, and people do have to take responsibility for some of their food choices. But like I say, we should track our dietitians. They're going to get a slice of pizza once a week. They're going to eat a donut occasionally. It's not like people are perfect, and even marathoning vegans are going to die. Nobody lives forever. So weight loss surgery is not about becoming a Spartan. It's not about living perfectly, because perfect is not sustainable in this world. It's about being able to have better appetite control, hunger control, and there are ways to manage that worse or better that I can't get into today. That's more in the patient information talk. But if you really think about these operations as tools, and most of the patients are going to already come in with that. You're not going to have to educate them on that, because to get to the hospital, they go through a big process on that of not thinking of it as a fix. It's not even a cure. It's a treatment. I've got a very successful treatment right now with my sleeve, but every day I still have to use that tool. Just like, you know, I have LASIK surgery now, but when I had glasses, every day I get up, put the glasses on. I mean, it's a good tool, but it's not you don't suddenly get cured and throw the glasses away. You know, it's part of your life. All right, so just to review the operations, they're on your card. I like going over them a little bit in 3D as well here too. So gastric bypass is the most common operation. It's not actually well, technically it's one of the oldest as well. It kind of went away for a little while in the 60s and 70s and then came back because it works so well. And this 3D model is very cool. I think a lot of times, so just to see, and you guys are definitely welcome to come to the OR. Let me show you the stapler first, actually, because I showed it second last time, and I think just some of the tools from the OR. So these are laparoscopic ports, like we use even for gallbladders or colon operations. We put them in. They've got their little trocars and make a skin incision. But then once it's in the softer tissues, it'll go through the muscle and the fascia real easy. And then we pull these little the liners out, if you will. And this is what you're left with, is these ports. You can put a camera through it. You can put these, too many things in my hands. The big one holds a stapler or a large camera, and you open it up when you're inside. I'll do it through the port. And you apply it.
Yeah.
You apply it to the bowel, and there, you can apply it onto the bowel to cut the bowel in half, or if you have an open bowel, you slide it. I already did it on this. I put 2 pieces of bowel together, but if you imagine another piece of bowel over here, if you put it here and then there's another piece of bowel over here, it's going to staple. See the blue to the red and the blue to the red and cut in the middle. That's how we do colon surgery. That's how we do colon anastomosis, right? Or small bowel resection. That's what this is. So imagine that small bowel. If we want to divide it, yeah, show and tell is fun.
Yeah, way easier to wrap your brain around.
So you'll see the piston on the back. This is going to push. It's going to put 3 rows of staples on either side of this blue bowel. This is an old stapler, so it's not firing that well anymore. They're built for 12 staple loads, and this is probably fired 200. So it's not going to sound real good. It may not. There it goes. All right. So that's all the way across. And then I push a button, and I usually have to manually. Oh, that pops open, and now you can see they're in 2 different pieces. Okay, and I'll pass them around, and then we can close that up and we can put other loads through there. Yeah, go ahead and pass that around. So there's 3 rows of titanium, little titanium wire suture on either side. So when people think staples, they think of a stapler. So you guys can see what, and you can see on this one, you put your finger through there how I connected those 2 pieces of bowel together. So this is the staple load down, and then I did one across. You can come to the OR and watch us do these, but then you'll know what you're looking at. Well,
Almost gonna be there tomorrow.
You guys are always welcome.
I had these surgeries. I'm really curious to see.
It's cool stuff to see. So now when I talk about dividing the bowel and dividing the stomach, that's what we do. We fire and we fire and we fire, and we divide. For gastric bypass, we make the upper part of the stomach about an ounce, about 30 cc's. Very small upper stomach. Here's the esophagus still attached. The lower part of the stomach stays in there for a gastric bypass. It's not a removal of anything for a bypass. So now we've got this little upper stomach. We go down below, and I always call this for the med students, tab A and tab B, right? And we count down about 50 to 75 centimeters below ligament of Treitz, and we divide the small bowel. Okay. So now this is A and this is B. We bring B. This goes down now to the lower end of the bowel, right? This goes out the bottom, out to the colon. Sorry, it's an old model loved to death. We bring B up and we hook it into the little stomach, the little new stomach. We sew that up, staple and sew. And so now when you swallow food, it goes down through this bowel, okay? That's bypassing the stomach. Traffic goes around town now. It doesn't go through the downtown. You still make gastric juice, you still make bile and pancreatic juice that come into the duodenum here, and we hook point A, end A, down into point C down here. Hook everything back together, and that is what's the Y part of a Roux Y gastric bypass. Okay? So this is, you're gonna know more than most doctors now. This is called the Roux limb or the alimentary limb. This is where food goes. This is the biliopancreatic limb, bile and pancreatic juice, right? No food goes through here. There's no digestion happening in here because there's no calories, right? Not much digestion happens in here because you don't have a lot of the enzymes. You get the brush border enzymes from the small bowel, but you don't have all those gastric juices. So this food just sort of passes through here, and it starts getting digested when they meet. Okay? Now people still pretty much absorb all their calories for the most part. So it's not really like they're pooping calories in the toilet. It's not like you still eat the same number of calories a day, but you do malabsorb iron. Your best absorption of iron is here. Your best absorption of vitamin B12 is here. Not going through there anymore. That's why you have to take more iron, more B12. So when we call it malabsorptive, it's more that the malabsorption of certain nutrients is changed. Yes, you do technically probably absorb a few less calories, but most of it is because you feel full. The trick of this is not that it makes you feel stuffed right away, it's that you don't feel that hungry in the first place, and then when you do eat, you do feel satisfied pretty quickly. Now,